Thank you, Sunita. So, we will talk about what are the general principles of symptom management and management of fever and pain in COVID-19. So, this is a very short presentation, and after that, I think we have to really discuss about the problems of COVID patients. And there are a few people who are really involved in COVID care.
But we should be safe.
So we will discuss a few patient stories. I hope Dr. Chandni can share with us some patient stories. The most important thing is if there is a symptom for a patient, whom should we ask? Because many times what happens is the patient comes with a caregiver, and the caregiver will be the person who is giving the most answers. So as symptom is a subjective thing, we should always get the thing from the patient itself. So this is the most important. We should get history from the patient, what he is suffering from, and what are the symptoms he is facing. And the basic principles which can be dealt by a mnemonic called EMA. EMA stands for the first E, means evaluation. Evaluation includes the history of the patient. Suppose it is a fever, we need to take many things like when it started and all those things which all of you know. So the history is very important, and then we have to examine the patient, and after examination we will do the investigation if needed, and then we will reach at a diagnosis. So evaluation which will lead us to a diagnosis, why this symptom occurred, what is the cause of this symptom. So that's what evaluation means. So the first E is for evaluation, and next is explanation. So once we found out a problem or diagnosis of the patient, we have to communicate it to the patient. So when we communicate it to the patient, it should be using a simple language. The patient should understand what are the problem he has. Suppose the patient has lobar pneumonia, we can't tell that you have lobar pneumonia, which the patient may not understand. So we have to tell using simple language, maybe something like you have infection in the lung, which you can translate into the local language so that patient will understand. And if you don't explain it to the patient, patient will have more anxiety. He may think of something. I have some serious things which is the cause of this particular symptom. So it is always important to explain to the patient regarding the diagnosis in his or her language. So EMA, E evaluation, and next E for explanation. And the third M for management. Management includes management of the symptom, which includes correct the correctables, non-pharmacological management, and pharmacological management. Correct the correctable, suppose the patient has a fracture, or if the patient has breathlessness, if it is due to pneumonia, we have to treat. That is the correct the correctable. Non-pharmacological management of breathlessness includes many things, including exercises or different types of breathing techniques. And pharmacological management include bronchodilators and things like that. So all this has to be done together if the patient has severe symptoms. So after we give medications for the symptom, we have to monitor the symptom. So how much the patient has symptom relief, what are the side effects of our medication. According to this, we have to titrate the medication so that patient will have optimal symptom management. And next is attention to details. So the patient, sometimes patient may not take medications at all, and patient may not have good symptom control also. So we may, by hearing that, oh, I don't have proper symptom relief, then we may add up many drugs to that. But it is important to ask them why you did not take the medication, so that we can understand why they did not take the medication, maybe because of the cost of medication or maybe because of the side effect of the medication. So it is important to inquire and find out all the details about what the patient want to tell us. So it is very important. So these are the basic principles of symptom management: EMA, evaluation, explanation, management, monitoring, and attention to details. This also includes when we manage symptoms, we should aim to improve the quality of life. So when we manage breathlessness, suppose the patient is in bed and we are giving medication, so that patient is able to walk around, so that we are improving the quality of life of the patient. So the quality of life is actually decided by the patient, not by us. Patient knows what is the quality of life for the patient. It is not us who is going to decide what is the quality of life of for that patient. And we involve many other types of paramedics or medicals, so that we can have good symptom control. In case of breathlessness, physiotherapist can teach the patient regarding exercises or breathing exercises. Psychologist and medical social worker can go deep into the emotions and other aspects, psychosocial aspects, so that patient anxiety can relieve, and then thereby reducing the breathlessness. And occupational therapist can also help in the management of breathlessness. Then we have to suppose the symptom is continuous, like breathlessness or pain. So in case of continuous symptom, we have to provide round the clock medication. So if it is pain and if you are providing paracetamol, we have to give paracetamol at least 6 hourly. So the duration of action of paracetamol is 4 to 6 hours. Likewise, each medication we have to provide as per the duration of action. And as far as possible, the treatment regime should be simple, so that it is clear to the patient as well as to the people who are working with us. And we have to always give a written prescription, so the misconceptions or confusions can be avoided. We know that many times when we verbally give an order to the nurse, sometimes they may not give the same medication which we have told. For example, we may tell that, okay, give cotrimoxazole. Sometimes the nurse may give clotrimazole. So it is important that a written prescription with correct dosage, timing, and what is the reason why should you take it, all those should be there in the written format. And in case if you are not able to understand or unable to manage the symptom properly, it is always important to take colleagues' advice, because he or she might be more experienced in the symptom you are going to manage. So if you are unable to manage the symptom, always get an opinion from the colleague. And patient may have many symptoms like fever, breathlessness, pain, but the symptom which causes more concern for the patient should be taken care of first. So if it is breathlessness, so we should be looking more at breathlessness, because it is causing more problem for the patient. So prioritizing symptom is very important. And many times we tend to give false reassurance, okay, that we can relieve that problem, but many times that cannot happen. And in such situation, we should not give any false reassurance to the patient or false hope to the patient. Instead, we can tell them that we can help you to reduce the symptom like breathlessness or fever or whatever it may be. So avoid false reassurance. So these are the general principles of symptom management in which we talked about EMA, evaluation, explanation, management, monitoring, and attention to details. And according to CDC, these are the common symptoms in COVID. Fever is the most common symptom, and it occurs in 83 to 99% of patients, followed by cough, fatigue, anorexia, shortness of breath, sputum production, and myalgias. So there is a controversy going on regarding the treatment of fever with NSAIDs. And it all started with the French health minister's tweet. He tweeted with saying that anti-inflammatory drugs can aggravate the infection. And so he advised to take paracetamol for fever. And many other people also supported this view. And they said that ibuprofen, it dampens down the immune system and which can slow the recovery process. That's what they have found out. And COVID-19 also interact with an enzyme involved in the regulation of salt and water in the blood. And it can also contribute to pneumonia. And they say ibuprofen can aggravate this. So these are the viewpoints that has come across. But after that, WHO has come up with this. WHO does not recommend against the use of ibuprofen. At present, based on current available information, WHO does not recommend against the use of ibuprofen. And they also said that we are consulting physicians treating COVID-19 patients and are not aware of any negative reports on ibuprofen beyond the usual known side effects. But this is from NICE guidelines, and which they published 2-3 days back. And they say fever is the most common symptom and it occurs usually after 5 days. And the management includes drinking plenty of oral fluids, and they don't advise more than 2 liters per day. And paracetamol is the preferred drug which they advise to treat fever. And in adults, the dosage is 0.5 to 1 gram every 4 to 6 hourly with maximum dosage of 4 gram per day. So this can be given either as IV or oral or parenteral. So if the patient has continuous fever, we can advise paracetamol around the clock. The duration of action of paracetamol is only 4 to 6 hours. So maximum of 4 gram per day can be given to the patient. Regarding arthralgia or myalgia, there are no much literature on how to treat myalgia or arthralgia. And one of the website from Harvard University, they advise to use paracetamol for treating myalgia and arthralgia. So we know that cancer patients are particularly vulnerable to the COVID-19 because of the immunosuppressed status. And these are the guidelines by American Pain Society and European Pain Society. And they say it is, we have to continue with ongoing opioid treatment regimes unless there are any changes in pain or any functions. So many patients who has cancer, actually 2/3 of the cancer patients can have pain and they will be on some type of analgesics, and many may be on weak opioids or as well as strong opioids. So we have to continue with the opioids which the patient is taking. And sometimes the patient, when end up in the COVID treatment center, they may not have any opioids with them, and they may also show maybe after 2 or 3 days they may show withdrawal symptom also. So it is important for us to understand that we have to continue with the opioid medications which they were using previously. So it might be difficult to get morphine, but I hope there will be injection morphine in the ICU setting, so that the injection morphine can also be used, or fentanyl can be used. And they also advise regarding to be careful regarding transdermal fentanyl patch, because in patients with fever, the absorption can be increased. So we have to monitor the patient more frequently if the patient is on fentanyl patch. So these are the guidelines, and we also understand that NSAIDs are not usually a good, not usually good medication for treatment of pain in many patients because of many side effects. The common side effect being gastrointestinal side effects, and in patients with hypovolemia, due to any cause, it can precipitate renal failure. And it can also increase the blood pressure. It can precipitate congestive cardiac failure. So there are many side effects which the NSAIDs can cause. So in patients with in this COVID, maybe there are many, some people recommend against the use of anti-inflammatory drugs. So we are not sure which medication can be used, can NSAID or steroid be used. These discussions are going on. But we can use opioids, which if you use properly, that will help the patient to relieve the pain or other symptoms. So that's about the short presentation. So we talked mainly about the general principles of symptom management, which includes EMA, evaluation, explanation, management, monitoring, and attention to details. And the management of fever, the NICE guideline recommend the use of paracetamol, and the maximum 4 grams per day can be used. So if the patient has fever, we have to use the paracetamol around the clock, at least 6 hourly. In case of pain, we have to treat the pain with paracetamol, or if the patient is taking any other medications or analgesics for pain, we have to continue those medications, including opioids. And we also have to understand that many patients may not be taking the opioid with them to the corona care center, and they may also show the symptoms of withdrawal after 2 or 3 days. So, which I think we need to prepare for that also. Thank you.
Thank you very much, Dr. Sunil. Is there any questions that anybody would like to ask regarding the session? Is there anything in chat? Nothing in chat. Yes, Doctor.
Dr. Narendra, you can unmute and speak.
Do our people have an experience with these tablets, hydroxyquinoline sulfate, VOH, 200 hydroxychloroquine? Is the tablet that is prescribed patient and some other supporters who are there? The latest coming up is Vermect. Ivermectin.
So,
Data is still available, but ivermectin tablet is a single tablet of 12 mg seems to have reduced the virus 6,000 times only they're experimenting. Do you have any evidence of late coming about this hydroxychloroquine? The beginnings they said hydroxychloroquine plus erythromycin in the beginnings. Then they said, let's stop erythromycin because they both are together, they're going to have some cardiac complications. Do you have any Indian experience about these tablets?
Dr. Anthony, would you like to answer that question?
Yeah. It's in fact the national guidelines and state guidelines. State guidelines, I mean Kerala government guidelines also recommends use of hydroxychloroquine in healthcare workers who are in close contact with COVID positive patients. That means we are actually treating, we are taking the throat swabs and we are seeing these people at not every healthcare, those who are actually seeing and treating these patients. That means COVID positive cases. So in those centers only, and asymptomatic close contacts of COVID positive. See, these are the two indications currently we use for prophylactic. That means before developing the illness, for prevention, we can prescribe. These are the only indications and not for all healthcare workers. And for treatment, our guidelines is usually actually recommending use of hydroxychloroquine and azithromycin in patients with COVID positive symptomatic. And if the person has not responded, we are in fact adding lopinavir, ritonavir also. That is the anti-HIV drugs. But if a person has non-cardiovascular illness, we may not be using the combination of hydroxychloroquine with azithromycin because of the risk of prolonged QT and the adverse effects due to that. So we are using and we have experience of treating these patients with hydroxychloroquine, azithromycin and lopinavir, ritonavir. But we are not using ivermectin, and as to my understanding, there is no guidelines currently recommends use of ivermectin for the treatment of COVID-19. Is that okay, sir? You have any more questions on this?
No.
Dr. Chandni, I have a question.
Yeah.
Thank you. Maybe in the whole group, there are very few who have actual experience of treating COVID. So your opinion is particularly valuable. Is it true that all the medicines that you have, Dr. Chandni has mentioned now, which are currently recommended, the recommendations are based on rather poor evidence? Is that true?
Yes, sir. Yes, sir. Recommendations are based on poor evidence, but actually in a context where we don't have enough evidence. For treatment, probably we have to sort something. And these three group of drugs we have tried in patients who have already had the illness and seem to be working. That is all we have. We don't have any definite concrete evidence to say that this is working, and the evidence for hydroxychloroquine also is very weak. So that is why, and there was a huge cry from the medical professionals to advocate hydroxychloroquine as prophylaxis, and I think that may be the reason that ICMR has come up with strict guidelines that only people who are having close contact with COVID-19 and no other healthcare workers should use. That is the message they are given. And I was thinking that the guideline itself came because of the most of the healthcare workers were taking hydroxychloroquine without any evidence, and in fact hydroxychloroquine was out of market because of the huge consumption by the healthcare workers. And there are many people like autoimmune disease and many other illness, people are actually using this drug for their treatment, and it was not available for them also. So that is the reason I think that ICMR has come with the guidelines. Sir?
Thank you, Dr. Chandni. That's very. Thank you very much.
Thank you, sir.
Anybody else having any other questions regarding the session or the
Yes, Sunita.
okay.
I have a question. If somebody is allergic to paracetamol, which is the next best option as an antipyretic?
Dr. Sunil, you want to answer that?
Yeah, I think we usually don't use aspirin because it can also cause problems. So maybe we have to go to NSAIDs, but we are not sure whether NSAIDs can be used now because of there are many controversies regarding whether to use it or not. There are people for it and against it. So maybe if you come across such a situation, you need to use anything to reduce the temperature, then maybe one of the NSAIDs.
Sunita, can I add something?
Yes, sir, please.
See, I find that among doctors, there is a prevalent confusion. Generally, so many reports came out to say that ibuprofen should not be used. So the consequence is that some doctors actually believe that other NSAIDs can be used. Now, ibuprofen was specifically mentioned because that is today the preferred NSAID. Since the news came out 10 years back that diclofenac is as COX-2 selective as other as COX-6, and that it can have 5 times more chance of coronary events. Ibuprofen is the universally preferred NSAID, except possibly in India, where most people continue to use whatever they were using for decades. So, first point, it is not about ibuprofen, it's about NSAIDs. Secondly, if somebody is allergic to paracetamol, then it would be cruel to leave them with myalgia and fever, which can be quite distressing. Now, in this context, actually, there's a question that has come up now. What about corticosteroids, which definitely has a potential problem? I'm not saying that I know this. Dr. Chandni may be able to explain better. I would recommend, my opinion would be, if paracetamol, if somebody is allergic to paracetamol and is in need of an antipyretic or analgesic, we should protect the stomach with a proton pump inhibitor. We should ensure hydration and go ahead, limited to 400 milligram 3 times a day. 600 milligram is unacceptable because there is evidence that that's a too much of a COX-2 selective action, and more than 3 times is not safe. But okay, I am not saying this because of COVID experience. I am saying it because you hear a lot and then it's based on the available information about NSAIDs altogether.
Oh, okay, sir. Thank you, sir.
I would, sorry, Sunita. I would like to get hear from Dr. Chandni also. I would say that corticosteroids, we do not know enough. It certainly has its potential effect. I mean, what if it prevents the body's immune response to the coronavirus and actually contributes to serious damage? Dr. Chandni, what do you think?
So I think as I understand and the guidelines, what they say is also steroids are not recommended. And obviously we all prefer paracetamol, and if at all possible, we would like to avoid all NSAIDs. And in a very rare situation, the person is allergic, and as sir has already said, with the severe symptoms. And most of the time, we are afraid of NSAIDs in the context of a febrile illness, not only in COVID, for that matter, any. And we usually don't advocate other than paracetamol. And in that situation, if the myalgia is the predominant and we need to have any other choice, maybe that is the only option left. But as sir said, taking into precautions and the lowest dose. But if possible, we should avoid NSAIDs because of the other consequences in the initial period, 4 or 5 days especially. Thank you, sir.
Okay. Thank you, ma'am. Any other questions? Okay. I think we were thinking that there isn't anybody who's actually seen COVID-19 patients or managed them in the group. Chandni ma'am, will you be able to talk about any patient that you have come across with COVID-19 and the presentation, what sort of symptoms they had and how were they managed?
In our institution, we are lucky maybe for that reason. We didn't have that severe sort of respiratory distress and presentations. All were milder forms. The patient has the features suggestive of a respiratory infection, and they come with cough and fever, and there is no rhinorrhea, like that. Simple, and usually which we can manage even at home, and especially when they have an associated illness like comorbidity, like chronic obstructive airway disease. One patient has a bit more sicker because of that. But my own student, one of the doctor physician in Manjeri, he has shared his experience in managing a patient with severe breathlessness. And in that situation, that person was already having diabetes, hypertension, and underlying heart disease. But we have given the same regime that we have already discussed, and luckily, patient has come out of this illness. But as sir has rightly pointed out, in an outbreak context, what I fear that our primary aim, especially if we know that there is human to human transmission, and even in situations where there is an asymptomatic spread, what we usually, our primary concern is to identify the patients who have high risk of transmitting the illness, and we tend to isolate them. And at that point of time, we usually don't have enough time to explain what they should do if they have milder symptoms like cough or body ache. We don't give any specific attention to their concerns. That is one aspect, because our primary aim is to prevent spread of the infection in the community and to curtail this outbreak as quick as possible. So most of the time, these people who are quarantined at home will not be having enough advice on what they should do for their milder symptoms. And this is one area probably we could have some specific interest and we can advise, because they are more of the time they'll be anxious, and if at all they complain anything, they feel that we will take them to the hospital and do the testing. So we need to have a way out that the anxiety should be alleviated, and their symptoms can be taken care of with paracetamol and other things, and they should be ready for proper transportation in the appropriate vehicle for further evaluation and management if they have symptoms like breathlessness and other things. So that is one area that we need to understand and we need to address. And second thing, when they have a comorbidity, we have already seen what is the problem with the opioids and if they don't get opioid. And similarly, most of the patients on diabetes or hypertension, especially type 1 diabetes or an advanced type 2, they are on insulin. So most of my patients, they had the fear that they will not get the drug. So they may go to a phase that there is no treatment, and the drug may not be available. The cost may be a problem because the government is supplying the drug, and if they have to buy, they may not be able to afford it. All those issues are also there with the comorbidities. And third thing is the guidelines and information. Every day new things will be coming up, and the guidelines and the treatment and the strategies and whom we should contact, everything will be changing, and we need to have a very regular update on what to do. So in that situation, if we are not really managing COVID-19 patients, because it may not be possible for every doctor into COVID-19, but all of us will be seeing our own patients in our own area. So what we can do is, if we really don't know how to go about with this, or if this symptom, do we really consider it as a COVID-19 suspect? So what we can do, that we can really discuss with our own colleagues who is doing it. So there will be officers, and we can get all the guidelines in the updated. So we should see what is happening, and we should be able to give them the correct treatment in the correct way. And we should also be able to select who should be doing and who should be getting the treatment, appropriate treatment. All those things we have to take into consideration. But most of the time, our concerns and efforts will be to control the outbreaks. It has to be there, but this has to be taken care of, addressing the human values and how we are going to move about. And in our center, we have not seen any of those severe or serious respiratory distress problems or problems related to whether to ventilate or not. But we are really prepared how to address this, because at that point of time, the equitable distribution of our available resources is really going to be a challenge. And I've been really addressing this issue to Rajagopal sir also. If we move to that phase, we must be prepared for that also. Thank you, sir.
Thank you, ma'am. We've also got Dr. Atul Joseph Mandel with here. He's a nodal officer for the telehealth services of Ernakulam district. Dr. Atul, would you like to share your experiences? You must have had phone calls from patients from home with symptoms and the concerns and worries. Would you like to talk to us about that?
Thank you, ma'am. Good afternoon. Like here in the telemedicine unit, so far we have handled around 580 calls of symptoms. And the trend that we are seeing right now is we are having primary contacts as well as secondary contacts calling us with symptoms now. So slowly we are seeing that numbers are going up. And regarding the symptoms, yes, initially classical symptoms were less, but nowadays, as we go by, we are getting classical symptoms. But the problem that we see is from around patients whom we shifted, around the 580, we had doubts regarding 20-25 patients whom we shifted for testing. But from that, only 3 or 4 has come out positive. So major of the symptoms were, as always said, it was fever, and very rarely they had diarrhea. Most of them had cough and fever along with sore throat in some. So these were the common symptoms that we have seen from the telehealth plans so far. And out of that, all the 580, except for the 22, we have been able to manage others at home itself. So since now the testing is just coming up, we are planning to test all the new symptomatic cases. But till now, symptomatic cases which we are able to make sure that they are home quarantined and room isolation is maintained, we have been able to do that. So those are the symptoms that has commonly come up here regarding COVID. But, I would like also to talk about the other symptoms which come along with COVID. So we are advising everyone, all the hospitals must start a triaging unit in their hospitals or clinics or everywhere so that they can fast track any respiratory symptom patients, because the mixing of patients should be minimized. So each clinic to each hospital should take their own call on how to triage the patients or basing on the basic guidelines, so that we don't get cross infection from patients. So now we are expecting a community spread might be there. So we have to be watchful, and triaging should be started everywhere. And common symptoms, as always talked about, is fever and cough in most of the patients.
So, Adil, I would like to ask a question, which I think will be relevant to most of the palliative care people here. So many of our patients will have many symptoms, but breathlessness and cough is one of the common symptoms. So if suppose a patient who didn't had any contact or any such history, and there is no travel history, and if they calls us and say that I have fever and cough for the last few days, what should we do?
So the general guidelines is anyone at this point presenting with fever, cough, sore throat, tiredness, or some with diarrhea, unless they are dehydrated, we should try to keep them at home in room isolation if possible. Especially if you have a vulnerable person at home, keep them strictly away from the person and follow the home quarantine rules for anyone who has these symptoms, because at this moment we know that testings are very low in our country. So more than testing, we need to isolate them. So just think of them as a COVID patient, though they are not tested positive. Isolate them at home, whatever may be the case, but follow them up so that we don't miss out on them getting their symptoms aggravating. So keep them on a regular follow-up who have symptoms. Maximum try to encourage care at home. If possible, in our district, we have devised a community pharmacy system where if prescription is needed, we give the prescription to the nearby PHC and they deliver medicines at home. So that primary focus is to enable people to be at home with low symptoms which can be managed at home. So we have to enable them to be at home because it's natural that everyone is scared right now. Whoever gets a fever is tending to go to hospital and get them checked, and they want them to be tested. So at this moment, since all the hospitals have not been equipped with the proper triaging technique, we always encourage everyone to be at home. And only thing is we have to follow up. Just to advising be at home won't be enough. We have to follow them up and give them required medicines as it is. The only one of the major criteria that we have seen is if there is a diarrhea, we have to watch for dehydration. Rest of the diseases, rest of the symptoms, we can manage at home. Only thing is if it's a vulnerable person with such kind of symptoms, we need to make sure that they don't have any history of travel. Otherwise, if there is a history of travel, definitely we need to get them shifted to a hospital because they can, the symptoms can go bad at any point.
So is your advice is to manage the patient through the phone calls?
Yes, sir.
Okay. Thank you, Adar.
Okay, I've got a chat message from Dr. Suma Radhakrishnan, who has mentioned that we have one more patient at Manjeri who's on lopinavir and ritonavir. Ma'am, would you like to talk about that patient if you know the details?
Yeah, I'm an ENT surgeon. This patient is an elderly patient who actually referred from my MES Medical College with atypical pneumonia, and he never gave any history of travel, even after repeated questions from all the hospital that he went. And on admission at MICU, on rounds also, everybody asked him, but he denied. But when the swab became positive with atypical pneumonia, we shifted him to ward, and he's an elderly with comorbidities, but he was started on chloroquine, azithromycin. Along with that, lopinavir, ritonavir was started after the medical board decision. And now he is stable. There is significant clearance of in the X-ray, and he is doing well. Stable so far. We have not yet completed the lopinavir, ritonavir. There is mild elevation of liver enzymes, so we are on. He is on follow in the ICU now.
Okay, ma'am, thank you. So we don't know where he got the disease from yet. That's not been traced.
No, finally he agreed that his son had come just 2 days back from after the Umrah, that from, okay, and that he denied in the initial interview.
Thank you, ma'am. Anybody else would like to share any experiences or any questions? There's some more things in chat from a previous discussion. So Dr. Charu has mentioned there's a high risk for patients with CKD, and the use of paracetamol and sweating and fever accompanied with furosemide for ARDS might cause acute renal injury. And Dr. Shobha has mentioned about steroids are used routinely for SARS associated fever and HIV and AIDS, which is under disease due to immunosuppression. Okay. Dr. Sunil mentioned in our group that you had talked with the doctors who looked after the patient in Kalamasheri and has a bit of idea about the history of the patient. Will you be able to share about that patient?
That was a middle-aged man, and he was isolated at home and later found positive for COVID. And then when he was shifted to the hospital, he had respiratory distress and he was on CPAP. But after I think 4 or 5 days, they had to intubate him, and they also told that the oral thrush is they saw oral thrush in that patient. So we were discussing about oral thrush. So but that patient died after I think after a few hours of intubation. So that's what I got from that physician.
Okay. Yeah.
That patient was intubated at night around 8:30, and by morning, early morning 3, he died. So that was a rapid deterioration.
Yeah. Okay.
One thing I would like to emphasize is on reverse isolation, ma'am, because especially we all are, most of us are dealing with palliative care patients who are the vulnerable population. So we must at least to our patients, we must be advocating on protecting them since the fatality of vulnerable population is high. So protection of them must be a priority regarding the palliative care settings in India, wherever we can spread that information.
Okay. Dr. Rajgopal has shared some guidelines on the chat. So April COVID-19 interim guidance on management pending empirical evidence from an American Thoracic Society-led international task force. So it's an empirical evidence. It's on corticosteroids for hospitalized COVID-19 patients with pneumonia. 15% for intervention, 18% no suggestion, 67% against intervention. I think it's come to me privately, so I'll just share it to everyone so you can read that.
Sorry, Sunita, I meant to send it to everybody. I mean,
Okay,
that was an accident.
I'll just do that, sir. Okay. So anything else that anybody would like to raise?
I would like to add something to. Sorry, I would like to add something to something that Atul said. When we advise, I mean, in palliative care, to palliative care patients, when we advocate reverse quarantine, I think if the palliative care center can make an arrangement at all, we should somehow make an effort to compensate for the horrendous isolation that these people are facing. There would be mostly people with cancer or elderly or with paralysis. The one thing that I could think of was a system where somebody gives them a ring every day, a phone call just for companionship. I think that would make a lot of difference. I do foresee major psychological consequences of such isolation.
That's very interesting, sir, because I just remember something that I'd read when all this business about isolation discussion was going on again from UK, that has anybody asked these elderly people whether they want to be isolated or not? So, they want to stay like that for the risk of losing their life. So I think it's very, very important when we say isolation and social distancing, what goes through the mind of these people is very, very important. We need to address that also.
And as sir said, it's not only in elderly. Isolation is a very bad experience, and in fact, I am in charge of the Corona Care Center, and there are people in isolation, and they used to call me and talk to me about their concerns. And now I am getting call from Dubai because his friend is in isolation in Dubai, and nobody is talking to him. So he's asking whether you will talk to him also. So this is a very good thing that we can give. It's a support that we should have a way out to reach all these people. That makes a lot of difference in their time.
Yes, ma'am. Once in a while, if we miss out to call people, because we follow up on a daily basis, if we miss out to call, they would call us and ask me, "Sir, I didn't get a call today. Have you forgotten about me? So please keep your calls going so that we can have a company once in a while."
Just to share something that Sunil and team are doing in Trivandrum. We have got together a group of medical social workers. Thankfully, many of them who had worked with us and later left us because of better jobs or because they got married, they all have volunteered. There's a group of 11 social workers engaged only in calling our people. Because COVID or no COVID, I mean, many of them were already very lonely. And now that this has happened, the loneliness is tremendous. So these 11 people are just sitting there and making calls every day to all our patients, not quarantined, but effectively socially distanced. It's not difficult. Only thing is we chose social workers because they are already aware of the principles of communication. If we are engaging volunteers to do that, then there will be there has to be a training program about what not to say more than anything else. And Chitra, to say that last week they made 350 calls to patients.
And when we call them, we are also able to find out what issues they are facing. Like often our role is also to coordinate Sometimes some medications are over, then we organize the medications to be delivered, or even groceries, or connecting them with community kitchens and such things. You know, very basic needs. Lot of work is done in those aspects as well.
Dr. Deepak has mentioned there's a good way to include maybe final year MBBS students, clinical psychology team, social workers to make these phone calls and video calls. Yeah, that's right. We need to increase the team who can support us.
And then I would repeat what I said earlier. There has to be an effective training program, specifically about what not to say. And also about I'm not suggesting a 5-hour session on communication. I am talking about a half an hour session. They should know what not to say, and a few things that they are safe to say, and particularly to learn to say, I don't know, when they are asked difficult questions, and pass the questions on to experts.
And I would like to share one thing we are doing here. We have given a portal now for people to register, and all from medical students to doctors, nurses, pharmacists, all of them. And within 2 days, we have got around 250 entries of volunteering. And by next 3 days, as said, sir, we are planning a e-module for on COVID for each category, video with presentations and with some couple of questions, so that they can complete it within 2 to 3 days, and we can even certify them if possible.
We had also trained 2,000 volunteers in the community after the floods to enable them to work as advocates in the community. So the database is shared with NHM, so that they can be also used for coordination of, to support people at the periphery.
Yes, ma'am.
Moira has asked about the ebook. I didn't mention that we have made an ebook, and that's in the process of being submitted to the government of Kerala today. The lots of content in the ebook will be taken in the forthcoming sessions, but I'll leave it to Rajagopal sir about sharing about details about sharing the ebook in the group.
Sunita, I don't think you should hesitate at all. Do please share it widely. I should have mentioned it earlier. What the government decides to do with it may take time, and we have absolutely no reason to wait for them to approve it or not. I think we should start. I mean, you have put in so much of effort over it. I think all of us should congratulate the team. How many of you, Sunita, who spent so much of effort on it?
The whole group was doing it together. We
yeah. How many?
How many, Chitra ma'am?
Anyway, okay. So this group has done a phenomenal work within about 5 days or so, and I particularly like the way it has been created. It's only thing is, Sunita, now that this is created, the team will have to keep updating it, because many of the new information will be coming in, new guidelines will be coming. At least a weekly updating will be necessary. But do please share it with everybody.
I think we'll share it in one of those website where we can have a link, and then once we update, we can send an email saying that it's been updated, because even APM guidelines, I think in 2 weeks they've updated already. So all the guidelines seems to be getting updated pretty quickly. So you're right, sir. We need to make sure one of us do that.
Rajeshri has sent a chat, Sunita.
So Raji ma'am has said, people who are asked to be on quarantine are instructed to do so without being inquired what quarantine means to them. This is miserable indeed. It's very true, ma'am. I personally had quarantine experience, so I wouldn't argue with that.
Because 20 days, myself. Since 23rd. Since 23rd, myself, Narendra, and Anil, and a group of 20 doctors or specialists, we are giving telemedicine sessions. And we have served so far about 1,500 patients from state of Andhra Pradesh, Telangana, and Karnataka. We are referring some of the people, the children. We got children specialists, the gastroenterologist, advisor, a cancer patient comes, We have got a cancer man in the team. We are now doing this work. Maybe I'm getting around 40 calls a day. Narendra is answering about 40 to 50 calls a day.
Thank you very much, sir, for sharing that.
Sunita,
We are
it's
at 4
time.
o'clock.
Dr.
It's time,
Siddharth
yeah.
Sharma.
Over to Raji. So it's 4 o'clock.
Yes.
Okay, we do have a feedback form that's in the chat screen now. So I'd be grateful if you could give a feedback for the session. It's just a link. If you click on the link, it'll open up a new page and you can just type in about the session and about the whole the course. And please give a constructive feedback so that we could improve in our sessions and for the next coming sessions. We can make the changes. So please do give constructive feedback. Anything else, Raji, from your side?
Nothing, ma'am.
I missed about the ebook. What are we going to do about the ebook, Sunita?
Sir said we can share it in the group, and we were telling whether we can put it in a particular website where it needs to be updated frequently, ma'am. So, so we can share the link of that. We can put it in a website wherever, and then we can share the link to the group so that they can click and view it. And when we are updating, we send an email saying that we have updated it.
Actually, I had asked Priti whether we can make it as version 1 because
Yeah.
we will update it. So if PalliCovid can upload it and few other websites can also upload it, it will be good. So sir should.
Chitra, hi. So we're just waiting on the last few changes by 7 p.m. By 9 p.m. The ebook will be up. We'll upload it as version 1, and then I suppose every few days, every week, we will add the following versions, or we'll
So
update.
then can we also then share it on WhatsApp and Facebook and all those things?
We'll make it shareable, yes.
Yeah, sure.
Moira has asked whether we can share about these sessions more widely, especially to government colleagues. So I've asked Atul to look in that, Moira, because he probably will know about which all doctors are. I think we need to make sure more people come for the session, and the effort that we've put in is actually for the doctors get the message. So we need to make sure more doctors come for the session.
I had actually spoken to Rajiv Jayadevan here in Cochin. I'll remind him once again to make it more kind of, market it or publicize it for us so that more people will join. Let's see. I think Praveena Raman is asking a question the second time. I think somebody should answer.
What makes this particular coronavirus strain significantly concerning? Anybody expert enough to answer that question?
Many answers could be there, but I really think Dr. Chandani should be the one to answer that. Particularly the concern about the virus being able to survive for much longer than we thought it could on any surface, and therefore the global impact being so horrendous. Shall we close with that answer to that question from if Dr. Chandani wouldn't mind answering that
Yes,
question?
sir. Yes, sir.
We'll
Okay.
call you.
Thank you. Thank you.
No. I was asking Dr. Chandani to respond to that question. In a couple of sentences, could you tell us why you think this is particularly concerning?
This is concerning because it's an outbreak or it's a pandemic than more than what we believed, because it's spreading like anything. There is a high risk of transmission. So we have seen it spreading from across the globe, and though the mortality is low, the number of people affected is so huge. So the mortality is going to be an immense burden on across the globe, and everything is shut off. Still, we are not able to control. So it is going to have a tremendous impact on the entire globe. So that's why it's a big problem, and we don't know how to treat it, and we know very little about this virus as a whole. And we have seen it's causing death, it's causing morbidity, and it's spreading so wide. So we need to take care of it. And it is symptomatic. People are really giving the transmission. So it's, as Dr. Rajeshri has already told, it's very difficult to ask a person to be in home if he's totally symptom-free. So we are failing in educating also in spite of all the efforts. I think that's all I could say about it, sir.
Okay. Thank you very much, ma'am. I think it's really, we need to stop at this point. Thank you, Dr. Sunil, for the wonderful session, and thank you for all for participating and contributing. We'll meet you tomorrow at the same time. Please do send feedback.
Thank you all. Bye.
Thank you.